In this video, we focus on subcarinal mesoesophageal excision, a critical step in radical esophagectomies to ensure complete mediastinal mobilization and lymphadenectomy. Mesoesophagus is a two-layered connective tissue coursing from the aorta to the left lateral aspect of the esophagus, which contains lymph nodes and esophageal vessels. The lymph node stations cleared here are 112 paraortic and 112 left pulmonary ligament limbs. The advantage being lesser blood loss along with more lymph node harvest, resulting in complete en-bloc removal, which prevents locoregional recurrences. The patient position is semi-prone, with the working port being at 5th and 9th intercostal space in the posterior axial line, and the camera port along the 7th intercostal space in mid-axial line. We start off with the posterior mediastinal pleural cuts as close to the azygous vein as possible. Here I am using a monopolar hook for the incision. Slowly we are progressing towards the hiatus distally. Below you can see the pulsation of the thoracic aorta. Here we have reached the lower end, the hiatus. Now we are starting off with the mesoesophageal excision part. Here we are using a bipolar sealing device, in this case a ligashure. Gradually we are sealing the blood vessels, which is coming from the aorta to the esophagus. That's the mesoesophagus, which contains the para-aortic group of lymph nodes. Gradually we are dissecting all the fibrofatty tissue and sweeping it down towards the esophagus for an en-bloc resection of the specimen along with the esophagus. Slowly and surely we are making some headway as we are dissecting. This is the anterior layer of the mesoesophagus, and that is the posterior layer of the mesoesophagus. This is the anterior layer again. Slowly you will see the white glistening adventitia of the thoracic aorta being visualized. This usually indicates a good clearance of the mesoesophagus. My left hand I have a grasper which is applying continuous downward pressure on the esophagus to open out the dissection planes. Slowly we are chipping away at the tissues, gradually cauterizing it, and gradual downward pull. These vessels need to be coagulated properly to avoid any bleeding, and thereby the field becomes hazy. It is always better to seal some bigger looking vessels at two places before cutting it. We are continuing the same chipping and chiseling and sweeping down the mesoesophagus. moving gradually towards the hiatus. Always staying close to the aorta. The transparent layer there is the opposite pleura, left-sided pleura, which marks the opposite limit of our dissection. We need not go any further into the pleura. So gradually all the fibrofatty tissue over the opposite left-sided pleura is being swept down so that it can be removed en bloc with the esophagus. Even if the pleura opens at this point, you need not worry. We will enlarge that rent. We need not put a left-sided ICD for that. We're reaching up to the hiatus. We're reaching the distal end of the mesoesophageal dissection. This is nothing but the left inferior pulmonary ligament lymph node packet. We're pulling the fibrofatty tissue, the left hand instrument, and sealing with the right hand instrument and sweeping it towards the specimen. Gradually reaching the hiatus, and visualization of the crus usually marks the end of the mesoesophageal dissection. This is the mobilized esophagus. Thank you for watching.